You're listening to Medscape's In Discussion series on cancer survivorship, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Ann Partridge, Professor of Medicine at Harvard Medical School, Vice Chair of Medical Oncology, Founder and Director of the Program for Young Adults with Breast Cancer, Director of the Adult Cancer Survivorship Program, and Eric P. Weiner, MD Chair in Breast Cancer Research at Dana-Farber Cancer Institute. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for use healthcare professionals.
Hi, I'm Dr. Ann Partridge. Welcome to Season 2 of the Medscape in Discussion podcast series on cancer survivorship. Today, we'll discuss cancer survivorship and fertility preservation. And I've got an awesome guest for us. Dr. Gracia is with us today. She's chief of the Division of Reproductive Endocrinology and Infertility at the University of Pennsylvania. She established the Fertility Preservation Program and sees many survivors as part of her practice. Welcome, Clarissa, to the Medscape in Discussion Cancer Survivorship podcast.
Thank you so much for having me, Anne. It's a pleasure to be here.
Yeah, it's a joy to have you. And over the years, obviously, we both have focused on this issue quite a bit in our research and our clinical care. What I like to do, especially when I know someone or I think I know them pretty well, is to ask them, and I always learn, what brought you to this focus in your clinical and research practice? Why do you focus on oncofertility in particular?
Well, I started practicing as a reproductive specialist in the 2000s, and in 2005, 2006, I began seeing many more patients referred to us after having had cancer treatment and really devastated about the fact that they had experienced ovarian failure and were unable to have children. And there was a growing awareness of the desire for survivors to pursue fertility preservation, and technologies were expanding at that time. So I got very interested and excited to help patients build their families in this way. And that's really been a passion of mine throughout my career.
And it was driven by seeing people who maybe had burned a bridge prior to seeing you and learned the hard way that fertility preservation is better than trying to deal with infertility?
Absolutely. Unfortunately, the options are more limited after cancer treatment has already been completed. It's certainly much harder for patients after they've already received chemotherapy, and often impossible to utilize their own gametes for reproduction. Whereas it's much better to talk to patients and strategize before treatment to figure out the best options for them to build a family in the future.
So like with many things, prevention is much better than treatment. Just hard to get systems together to buy into it. Just stepping back a little bit, though, what are the reproductive risks associated in general with cancer therapy? I realize that's a big question, so break it down how you like.
Yeah, I mean, there's a lot of factors involved. In particular, what type of cancer does a patient have and what treatments are planned are obviously critical. The most damaging treatments tend to be certain chemotherapeutic agents like alkylating agents, for example, that destroy eggs and sperm and reduce the number of eggs available in the future for patients. Radiation directed to the pelvis can also damage the ovaries, uterus, and testes. And obviously, surgical treatments to remove or change the anatomy can interfere with reproductive function as well. And then finally, patients with brain tumors sometimes need to have pituitary or brain radiation that affects the pituitary function and can cause amenorrhea or the lack of the signals which are necessary for the gametes to develop normally.
So it sounds like it's multifactorial potential, although for any given individual, obviously you have to tease it out and not everybody gets every treatment. What are the barriers in terms of both understanding an individual's risk as well as discussing that risk and fertility preservation with those patients? Recognizing you're not necessarily the first person that sees them unless they were diagnosed in the reproductive endocrinology suite, which happens sometimes, at least with my patients. But what do you see as the barriers along this process?
Yeah, so I think that when a patient comes in, sometimes it takes a while to get an actual diagnosis. and also figure out exactly what treatment is going to be administered. And sometimes that takes time and the clock is ticking. Patients can be sick, and certainly top of mind for oncologists and for the treatment team is to get the patient diagnosed and treated so that their cancer can be cured long term. Often there are some assumptions that are being made. So, for example, somebody who has a child already, maybe people don't think, oh, this person may want to have additional children in the future. The prognosis may be very poor, and the clinicians may think, well, they may not even live long enough to have additional children. And then in terms of socioeconomics, I mean, fertility preservation sometimes costs quite a bit of money and is not covered by insurance. And there are assumptions made about patients' willingness or ability to pay for some of these treatments. And so I think these are just some of the factors that can play into why patients often are not referred in a timely manner to really talk about their options.
Yeah, I'm struck by even that point of there are systems-based problems, but even the barriers for providers like me, people taking care of patients with cancer, helping them make their treatment decisions, especially in the curable setting, but it's even harder in an incurable setting or a potentially high-risk setting to even have the conversation. Do you have tips about that or things you suggest to your oncology colleagues for how to manage this?
I think it can be tough to have conversations with people in particular who have a very, very poor prognosis, because you need to think about what's your life expectancy. Would you consider having a child even if something does happen and you die? Do you have a partner who will take care of that child and so forth? So I do tend to have many of these conversations, and they're very difficult. But I think that it's best to be honest with patients and really give them the options to actually pursue fertility and to think about these issues. Because at the end of the day, I think these are hopeful. We're talking and giving patients a lot of hope when we're talking about the future and the possibility of building a family rather than just survival. We want to make them understand that it is possible to actually live and have reasonable quality of life and have things that, the rest of us are able to have in our lives. And that is true, thankfully, thanks to all of the incredible treatments that now oncologists are able to offer their patients. Patients who I thought would never survive are now surviving many, many years and building their families and living, very fulfilled lives.
Yeah, we talk about with our patients, and they tell us not just surviving, but thriving, as you know, and having what they want. And to that end, maybe we could go through, let's start with women and girls. What are the options for fertility preservation? And then we can talk about male issues.
The options for, women and girls for fertility preservation really boil down to three things. 1, banking eggs, 2, banking embryos, or 3, banking ovarian tissue. Egg banking we typically reserve for patients who don't have a committed partner, who are young, and typically who are post-pubertal, so they've already gone through puberty and whose ovaries will respond to ovarian stimulation. And the process is very similar to embryo banking. The only difference is that we fertilize the eggs and create embryos for cryopreservation. For both options, women have to go through the process of stimulation, which requires taking medication, so gonadotropins or follicle-stimulating hormone, to cause the development of multiple eggs in the ovaries so that we can collect eggs and put them aside, or fertilize the eggs and create embryos. That process is pretty intense. Patients have to come in, every few days for ultrasounds, typically vaginal ultrasounds or abdominal ultrasounds, and blood work to measure hormone levels, and then undergo a minor surgical procedure, which is typically done under sedation, where we put an ultrasound in the vagina with a needle attached. We go into the ovaries, aspirate the fluid in order to collect eggs. It's rare to have any complications from that procedure, and typically patients are able to go home the same day. So how successful is it? Well, when we bank eggs, we usually tell young patients less than 35 years of age that the success is about 6 to 7% for egg frozen. Many women will produce multiple eggs in one cycle, so anywhere from 5 to 25 eggs potentially can be retrieved. And the cumulative success really depends on how many eggs we have. For embryos, we take the eggs, we fertilize those eggs, grow the embryos out to the blastocyst stage, and typically freeze blastocysts, which are embryos with 100 to 200 cells. They have a higher chance of survival, and they've already kind of proven themselves because the eggs have fertilized and grown out. And so we have more confidence in those embryos. For each embryo we freeze in a young patient, there's about a 50% chance of having a baby per transfer. Success rates for both of these options go down as women get older. Over the age of 40, success rates are quite low. So that's important for counseling. The other option is ovarian tissue freezing, which typically is reserved for patients who have not gone through puberty yet, have a very short time to treatment, so we don't have enough time for a 2-week stimulation, or have already received chemotherapy and aren't great candidates for egg freezing. So in those situations, we can perform a laparoscopy, typically go in, remove either a piece or an entire ovary, divide the ovary up, and then cryopreserve pieces of the ovarian cortex. Later, those pieces can be transplanted back into a woman's body, and there's about a 25% chance of pregnancy with transplantation in young patients. But again, that technology is much newer, and there's not as much information on success rates for that.
Is that still considered experimental, or can people get that everywhere that you can get other more standard IVF procedures?
That's a great question. While the American Society of Reproductive Medicine does not consider it experimental, because there have been now close to 200 births reported from this technology, I would say it's still an emerging technology, and it is definitely not available everywhere. It is becoming more and more available in the U.S., particularly at pediatric hospitals and in some adult hospitals, but it is harder to come by, and so that's definitely an access issue for patients. It's much more common in Europe, and it's kind of a standard procedure in many countries there.
And what about, let's just shift gears, what about the men and the boys? What can we do for them?
So the standard fertility preservation option for men and boys is really freezing sperm, and typically adolescents, reproductive age men can, collect a sample through masturbation, and then we can take the sample, we can divide it up into various vials and then freeze that sperm. That has been a successful method of fertility preservation for decades now and works very well. The challenge is getting patients to actually do it before the cancer treatment or chemotherapy starts. So there are still access issues, even though it's a relatively simple procedure, and one would think that, most people should just get it done. For boys who are prepubertal, there really are no established techniques. There are some institutions that offer an investigational approach to testicular tissue freezing, where they take a sample of testicular tissue, freeze it, and then hoping down the line they'll be able to mature the tissue and grow sperm in a dish to use for IVF. But that still has not been possible in a human.
So that's still highly experimental, although I'm sure there's a lot of work going on.
There are. In terms of the GnRH agonists, I did want to mention that there's been a lot of controversy on that topic and whether it truly preserves fertility. Nonetheless, at least in breast cancer patients, there have been a number of trials that show that it does reduce the risk of ovarian insufficiency and menopause, early menopause. And so it is an adjunct treatment that we sometimes do give to cancer patients. But I would say it's not sufficient to preserve fertility, and there's still a lot of controversy about whether it actually protects your fertility or improves your long-term pregnancy rates.
Right. Very controversial. And we give it, but I don't think we assume it's going to work. So we give it with the caveats of not so clear, and we give it as an adjunct, or we do it and if we can't do anything else and someone really wants to receive the suppression through treatment. One of the things that also comes up is in survivors. What about pursuing fertility preservation or infertility treatment after exposure to chemotherapy? How do you assess that, and how do you think about that and counsel patients?
Yeah, I do see a lot of survivors who've already been exposed to chemotherapy, perhaps as a child for childhood cancer, and then they're not yet ready to have children, maybe they're in their late teens, 20s. They haven't found a partner yet. And so they are interested in figuring out, well, can I put some eggs aside or do some fertility preservation methods? And it may be an option, but it depends on the ovarian reserve of that individual. We can test ovarian reserve by doing a couple of things. One, we can check a hormone called anti-Müllerian hormone. That is a hormone secreted by the granulocyte cells around the follicles. And the more AMH there is, the more eggs there are. And that correlates well with your response to stimulation, how many eggs we'll be able to get, for example, for egg freezing. So that's a critical piece of information. We can also do a vaginal ultrasound and count the antral follicles to determine how many eggs follicles we see. And that's also a measure of ovarian reserve that can be useful. And so after we get that testing done, then we have conversations about, well, is the patient a candidate for egg freezing, for example? What would that look like? In some cases, it's not clear and we try it. And then depending on the response, if the patient is only producing 1, 2, or 3 follicles during a stimulation, as I mentioned, the success rate per egg retrieved is low. So then we have a conversation, well, do we really want to go for it and collect the eggs and freeze them, especially since the patient may be having to pay out of pocket for this procedure and then pay for long-term storage down the line. So those are things to really discuss and figure out the risk-benefit ratio in each case.
Another thing that comes up is the issue around patient's genetic predisposition to the cancer and not wanting to pass it on to their progeny. How do you manage that in your practice when you're seeing these patients who are interested in, either fertility preservation or are infertile after treatment or subfertile?
So often we don't have the genetic information at the time of the cancer diagnosis, and we just freeze eggs or embryos, and then afterwards, patient come back and they say, oh, I have a BRCA mutation or, another one of these hereditary cancer mutations. At that point, we have to look at what their own ovarian reserve is. Could they go through the stimulation again? Or do we have enough eggs or embryos in order to test those eggs or embryos to prevent passing on the disease? The testing does require finding out the specific mutation, developing probes in collaboration with a genetic testing company in order to actually detect the mutation, and then doing a biopsy of embryos, either from the frozen eggs or the embryos that are frozen, taking 5 to 6 cells off the embryos, sending it for genetic testing, and then determining which embryos are normal or unaffected and planning to transfer those. It does increase the number of eggs and embryos required, as you can imagine, and many people who know they have a genetic mutation that they want to screen for through PGT have to go through 2 or 3 rounds of IVF in order to get enough eggs and embryos to actually have sufficient unaffected embryos to have a baby. And that's one piece that I think people don't really understand, and it's an important concept because the cost, in terms of counseling, it's important to understand that often it's just not one and done egg retrieval and you're going to have plenty to build your entire family. So that's part of the conversation that has to happen.
Sounds like a lot of your work is around hope, but also managing expectations.
Absolutely.
What about other options for building families? What do you talk to patients about?
Yeah, so I always mention that there is always a way to build a family no matter what situation somebody is in. It is possible to use donor gametes, donor sperm, donor egg. It is possible to get embryos that have been left over from other couples who've gone through IVF and use those to conceive. It's also possible to have someone else carry a pregnancy for you and use a gestational carrier. So for me, really, all we need is an egg, sperm, and a uterus, and we can figure out how to utilize it to build a family. And then even aside from that, it's important to talk about adoption and fostering as alternative methods because plenty of patients are happy with those options and may decide, maybe I don't want to put myself through fertility preservation. Maybe it's too expensive. Maybe I'm too old. And so if they know all the options available and some of them are reasonable and acceptable to them, those may be really good choices for a patient.
As usual, it was such a treat to connect with you. Today, we talked to Dr. Clarisa Gracia about the importance of fertility preservation and care for cancer survivors. Thank you for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on cancer survivorship. This is Dr. Ann Partridge for the Medscape in Discussion Cancer Survivorship podcast.
Thanks for listening to Medscape's In Discussion Cancer Survivorship podcast series with our host, Dr. Ann Partridge. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on cancer survivorship.